So let me introduce you to our next three panelists. To my right, we have Jacqueline Matoro. She's a health specialist, Swiss Corporation Office in Tanzania. Besides earning a master's degree in public health from the University of London, Jacqueline Matoro graduated in Ireland with a master's degree in development studies. Ms. Matoro has performed the role of health specialist for Tanzania since 2004, and she will help us to understand the national perspective and role of a donor in Tanzania, which is a priority country of the Swiss Corporation. And then we have Dr. Ntuli Kapologwe. He has a master's degree in public health from 2013 till 2015. He studied here in Basel and studied at the Swiss Tropical and Public Health Institute, where he earned an MBA in International Health Management. And since February 2014, he has held the position of Regional Medical Officer in Shinyanga, Central North Tanzania. And he will bring in the local perspective and role of the local authorities in the day-to-day project implementation. And then we have Susanne Amsler, health specialist for global health at the SDC headquarters here in Bern. Before specializing in global health through various forms of training, Susanne Amsler earned a master's degree in social sciences at the University of Lausanne. Ms. Amsler began her career assisting and collaborating in projects based in Mali, in Tanzania, and in Switzerland. And from 2009 to 2011, she worked as a UN project manager in Tanzania. And she will represent the global and Swiss perspective and role of a donor at an international level. And you will have the possibility to send in your questions via SMS. We will answer your question, if you have any, within the last 5 to 10 minutes of our panel here. So please feel free to send in if you have any kind of question. You can send it in by German or English, and we'll answer it right up front. So I'd like to start with you, Ntuli Kapologwe. We've seen in the film people registering very graphically with the mobile phone for the health insurance now. Can you tell us about the health insurance situation in general in Tanzania? If I'm right, I saw this is just one district where this is happening right now. That's correct.
Thank you very much. First of all, I'd like to register my sincere thanks to SDC and the people of Switzerland for supporting the people of Tanzania through the health promotion system strengthening project. Secondly, I would like to register my personal thanks to the SDC for having invited me to represent my country.
Great to have you here.
Thank you very much. The history of Community Health Fund as an insurance scheme started way back 20 years ago when we piloted in one of the districts in Tanzania. But since then, it has suffered a number of challenges. One among few challenges was inability of people to be registered from different areas of Tanzania, and also poor governance of the scheme, also poor transparency and finances. And that was the reason behind why Tanzanian government had to request the Swiss government to come up with a project which will strengthen the health system, especially on the insurance funding.
Which challenges were the hardest to tackle in the beginning? You've named a couple of them.
The biggest challenge was indeed trying to change the mindset, especially of healthcare providers. They were used to enroll people at the healthcare facilities, which is contrary to the insurance principles, which emphasizes on the separation of function between providers and purchasers. But that was contrary. So with new project, especially health system strengthening project, we have separated the function of providers and purchasers. And that has reduced what we call moral hazards and adverse selection, because initially we could only enroll people who are sick. And that posed a great challenge to the viability of the insurance scheme. But with the new one, and health promotion system strengthening project, it has reduced that problem, and we can see now the scheme is quite very viable, and indeed it can be sustainable.
Can you elaborate a little bit more about what kind of services are covered now by the community health funds?
There are a number of services which are covered. but these are under what we call the minimum benefit package. This minimum benefit coverage includes number of services, not few services. I think it will be very difficult for me to be able to mention all the services. But maybe in a nutshell, it would be the top 10 diseases in a local area, and also minor surgical services. But for other big services, you need to co-pay. We need to do what we call co-payment.
Maybe I could ask the next question to you, Ms. Matoro. Why did the Swiss corporation decide to support the project in the first place?
The project is a mandate from the Ministry of Health, basing on the experience of the Swiss government implementing a health project in Dodoma region. We started with a rural health insurance project to pilot and see what could be done to improve the community health fund enrollment. So the government acknowledged our effort by also sharing our experiences and challenges, and this was done at the policy level. So through this, they asked us to see if we could pilot another project now at a larger scale, covering the whole region of Dodoma, which has 7 districts, because initially only working in 3 districts in this small pilot project on rural health insurance.
What were, if I asked before Mr. Kapologwe what the challenges were that they had to tackle, what kind of challenges did you have to tackle in the beginning?
One big challenge was with data management, because you have to have the data of the enrolled members. This was being done manually. There was no electronic way of managing the data. So it was taking so much time of the health facility workers to write down the names, the age, and where the people stay. And also, because you don't have a proper data management, you cannot go back and see who was re-enrolled again after the enrollment period comes to an end. So that was one main challenge. And then the other one was with behavior change. There was no awareness raising of people to enroll, because enrollment was being done at the health facility, not at the community level. So it's only the sick, as Dr. Ntuli has said, who are going to enroll, but not at the community level.
And it also seems very complicated in the beginning, like when you had to have your card with the whole family, and once the card was lost, your insurance was lost, basically.
Yes, because the card was only being held by one member of the family,
Right.
one card for 6 members of the family.
Right.
And this is usually the head of the household, the father. So if the father goes away from the house and there's somebody who falls sick at home, then it becomes difficult to access the health services.
Yeah. Ms. Amsler, is Tanzania just a simple example, or does the Swiss corporation have similar projects now if we go from a district, a national, to a global level with you?
Thank you. SDC does support projects that have aspects of health financing, or more specifically, aspects of health insurance in other countries or regions, such as the Great Lakes region, in Chad, or in Benin. Usually what we see that the context, I'm taking now as an example Sub-Saharan Africa, the context is very similar to Tanzania in the sense that only a little percentage of people are covered by health insurance and are enrolled in a health insurance scheme. Usually, those who are enrolled in a health insurance scheme are not the poor and the poorest. What is then very different from one country to another is the priority that those countries have, the needs that the countries formulate. So it's certainly not a copy-paste of one project like the HBSS in Tanzania to another country. So similar projects, but not exactly the same.
What would be the learnings, perhaps, that you already can draw from that project in Tanzania that you might implement in other places in the world?
I think one of the learning is certainly you start with an assessment. Usually you already have some forms of insurance schemes. You start with an assessment to see what has worked so far, what are the needs also of the populations. They know the best usually what was challenging in a health insurance system and whatnot. And I think another very important lesson learned is that a health insurance scheme is one part of a whole health financing strategy, I would say. We had periods where healthcare was free in some countries. This is great for the population, but it's certainly not sustainable in a long run because the health services are very costly. So now it is important, and many countries focus much more on the question of health financing to see how can the health system be financed in a sustainable manner. How can the funds that are collected by health insurance be used then? Should it be invested into the buying of medication, or in which way should the healthcare system be improved, etc.? So I think linking the health insurance to a wider health financing discussion in the country, that's very important.
So people can afford to be in that scheme in Tanzania?
Indeed, they can afford.
Yeah. Can you provide us perhaps some concrete examples what changes the project brought to the community health?
There are a number of changes.
Perhaps you can take your microphone just a little bit
closer. There are a number
of
changes the project has brought to the people of Tanzania. I'll mention a few. The first one is with medicine management. Prior to the project, we have had a big problem with stockouts. And remembering the baseline survey prior to the inception of the project, medicine availability was between 20 to 30%. But after the inception of the project, introduction of medicine audit, medicine availability has increased to 90%. And the other thing is we have had some problem or challenges with procurement system in Tanzania, because medicine management has been monopolized with one agency, that is Medical Stores Department, and that could also contribute into medicine stockout. But with this project, we've been able to introduce a new system, what we call prime vendor system, whereby we pre-qualify the people in the private sector, and these cooperate with the government to be able to offer medicine when the medical stores department cannot offer. Also, this project has been able to help the Tanzanian government to task shift, because of 100%, I would say only 20% of medicine management is managed by the pharmaceutical staff. The rest is managed by non-pharmaceutical staff. So through training on medicine management, we have been able also to train the nurses. Nurses are able to manage medicine. And not only that, also we have been able to get leadership and governance courses. I'm among the beneficiary, so that I can be able to manage well the scheme. So there's a lot of benefits which we have got from the project, but those are the few to mention.
Thank you. So how exactly does the Swiss corporation contribute to such changes? How does that work?
We are working very closely with the government of Tanzania, especially the Ministry of Health, and we have a bilateral agreement that really defines the objectives and the expected outcomes of this project in agreement with the government. And at the government level, we have a dialogue structure that we bring in the evidence-based information that is coming from this project at the policy level, where we discuss the different challenges and what are the successes that we are seeing out of this. So basically, what SDC is doing is knowledge generation that can be used for decision-making at the policy level. Yeah.
And so Tanzania was ready for that? Or did you have some problems in the beginning to really get the kind of attention that you were looking for?
There's a very clear dialogue structure in Tanzania. So we use the already existing forum to bring in the different issues. And also because of the fact that SDC is an active member of the health sector, so it gives us that leverage to really bring in the different project experience at the national level.
You've mentioned some numbers. How much has the number of registrations increased since the beginning of the project?
Yeah, initially prior to the inception of the project, we have had about 2 to 3% of people enrolled into the scheme. As I'm talking to you, we have 12%. 12%. Okay. And initially, we could not ascertain whether it was 2 or 3% because our information system was very poor.
Okay.
To be able, really to ascertain whether you have 2 or 3 or 5%. But in addition to that, the Health Promotion and System Strengthening Project, it has been instrumental in formulation and development of number of policy documents. I'll mention 3. We have the Health Sector Strategic Plan 4, which will soon start to be used, which starts from 2015 to 2020. And also we have Health Financing Strategic Framework, 2015-2025. All these policy documents have been developed partly by the HPSS. Yeah.
All right, so if we talk about costs, how much does a registration cost?
Indeed, if you were to compare prior to the project, I would say now it's quite very cost effective. It will cost around, I would say, $10, but initially it will go up to maybe 20 or 25, because one has to travel a very long distance just to take a passport size photo, right. And also one has to go to the health facility for him or her to be registered. But now, after separation of function, enrollment is taking place at the community as compared to a previous time when it was taking place at the health care facility.
So you mentioned $10. That's
yeah.
Right, yeah. And can anyone and everyone afford that?
They can afford, because now the decision to put the what we call premium fee, it is with the local government authority. Are the ones, the councillors are the ones who decides how much should be contributed to.
Okay, right.
It's not like a top-bottom approach. Yeah.
So how does the Swiss corporation address this challenge, perhaps, for poor that may not or might not benefit from the project?
The Swiss Development Corporation has been very active in the development of the health financing strategy, the first health financing strategy for the Ministry of Health, that has taken in one component of the insurance. So in the process of developing this health financing strategy, there are several studies that were undertaken. And SDC played a very important and crucial role in trying to understand how to include the poor who cannot afford in the insurance scheme. So we did a study of inclusion of the poor, and also brought in the issue of how do we identify the poor, because it's quite challenging on how to identify the poor, or else everybody will come out and say, I am poor. Right. So there is a criteria for identifying the poor and knowing what is the percentage of the poor in the as the population of Tanzania. Right. So with this study, it has enabled the Ministry of Health to now know what are the number of poor people that need...
Are there already hard numbers, hard facts?
There's an estimate also basing on a household budget survey to really know how many can be covered in terms of the government paying for them, as now we are moving to a mandatory single national health insurance scheme. Yeah.
So if in a few years, let's say, everyone will be insured in Tanzania, will the main health problem in Tanzania, the main health problems perhaps, have disappeared?
I think so, because with compulsory health insurance, then there's risk and financial pooling, and that will help a lot in reducing the chances of few people suffering from certain diseases, as compared to now, where by the enrollment through CHF or community health fund is voluntary. But if it's compulsory, then we shall have enough funding to be able to deliver different services to the people.
So, in short, the medical infrastructure also and health services in general should be strengthened at the same time to ensure that, correct?
Indeed, indeed. And looking into the components of Health Promotion System Strengthening Project, it has 4 components. One on the issue of health technology management, the other one in medicine management, while the other one in health financing and health promotion. And the health promotion component is where also it supports infrastructural development. Also, apart from HPSS, we have also some other partners. So as a regional medical officer, what we are doing is to try to coordinate all the partners who are working in the region.
So the whole interconnectedness, yes?
Yeah, the beauty of the health promotion and system strengthening project is that it works in an integrated approach. Dr. Ntuli has mentioned the 4 components. We are really trying to address the demand and the supply side of the health service delivery. So you find with the health promotion, there's a lot of a community awareness, community empowerment, and also people taking charge of their own health issues. And on the on the supply side, the medicines management is very important. It's a crucial component that really ensures that people continue to enroll. Because if you enroll for this community health fund, and then you go to the health facility, you're told you go and buy medicine outside the health facility, you'll not really re-enroll again the next time, because people are trying to avoid out-of-pocket payment for health services. And that's why with the community health fund, it is a really crucial social protection mechanism for especially the poor people and people in the rural community. So if drugs are there, then this gives them confidence to enroll again for the community health fund.
Yeah. To ensure it.
And also because you're also working on health technology management that is looking at equipment management. If you cannot be properly diagnosed, maybe there's a broken microscope, then the doctor just tells you have malaria without going through the test. That will not give anybody confidence to go to seek health services, because it's important if your doctor uses a well-working equipment to diagnose you that you're sick and you feel like, yes, time has been taken and the equipment that has been used is of good quality and the diagnosis is correct because of the equipment.
Also, the credibility of the system is really strengthened with that. Would it not be easier or just better even to support a project that actually prevents people from falling ill in the first place?
We say prevention is better than cure.
Right.
And that's very well addressed with the health promotion component. We are seeing a lot of community awareness. Communities are developing their own plans after identifying their different health problems in a participatory process. So they really list down the number of diseases that they see that is taking place within their communities on a frequent basis. So from this list, they come up with solutions and then come up with action plans. Very good example is now there is real sanitation project that is taking place at the village level. Almost all households now have latrines, thanks to health promotion component, because they are doing a community-led total sanitation. There's no more open defecation. People are using pit latrines that they are constructing through the project support. And also in schools, because we believe that students are very good change agents, there are a lot of school health activities that are being promoted by the HPSS under the health promotion component. Their school clubs, they do a lot of screening of different diseases like worms, if students have worms, and eye diseases, eye problems, ear problems. So those ones who are found to be sick, then they're referred to the health facility. And this is being done by the health facility staff in collaboration with the project team.
And on a community, local level.
Exactly, yes.
Ms. Amsa, is this how, if we get your international perspective again into this panel, is this how the Swiss cooperation works in most health projects now?
I would say that this project very well shows the complexity of a health system and shows the complexity to a certain extent of reality. We started with the question of, or the challenge that people can't afford health care, they can't access health centers because of a financial challenge. But then once they're there, is the infrastructure there? Are the people qualified healthcare staff there? Is the medication there, etc., etc.? So I think those are the questions that we try to see when we start any kind of health intervention. It doesn't mean that a project needs to cover all these different aspects because it's quite challenging. In the first place, you may need to prioritize what is the most important issue to cover. For example, the medication part of the HPSS came out quite clearly by the population. They said they really perceive it as one of the major challenges when they go to the health center. So I think it was very important to hear also from the population what they think are the main elements in the healthcare system that need to be strengthened. Maybe a second point is that we try to collaborate and coordinate with other donors, be it in Tanzania or in other countries and internationally as well. For example, in Tanzania, Switzerland is less active in the area of human resources for health, investing in trainings for healthcare staff, but other donors do. So it's very important, as Jackie has said, that at the national level, there is a coordination among donors. Then another point I think that is very crucial for any kind of project, and we heard this several times now, is that you may know all the important elements of a healthcare system, the infrastructure and the health personnel, etc. But you need to know what are the perceived barriers by people. Maybe all the elements of a healthcare system are there and people may not come to the healthcare system. Simply because there's some delicate issues that the woman would like to discuss maybe with the female healthcare staff. Some health issues that a man would like to discuss with the male healthcare staff in some societies. We have seen the project of Moldova, and I think being able to discuss with peers of your age some very intimate issues, I think that that can be a very appropriate manner. So the perception of the people, how they see the healthcare system and what they need from the healthcare system, that's very important to bring the people and their needs together with the system. If I may add just a very last point, I think what is very important from the beginning in any kind of project is to have a longer term vision. From the beginning we said that this project would probably need about 10 to 12 years to really be at the level that you can maybe say you have a health insurance system in Tanzania. So it's certainly not done in 2-3 years, even if you're looking for quick results. So it's much more complex than that. This also means a commitment from the donor for a bit longer term. And then my last point maybe in terms of sustainability. I think the project, it's challenging, but the project shows very well that all the aspects are implemented by the government, by the community from the very beginning. So SDC is not covering for running costs, and all of a sudden the question is there, but who pays the salary of the healthcare staff? What SDC is doing is through the Swiss TPH that is implementing the project, paying for technical advice, but also paying for one-time costs like the development of the software to manage the health insurance system. So I think in terms of sustainability, that's very important to have these questions in mind from the very beginning of a project.
So, Ntuli, how do you ensure, or how do you know that the project is successful first and people can access the services they need? How do you measure that?
Yeah, we have the information system in place, which was partly been constructed by the HPSS project. So we have a number of indicators in it, and through these indicators you can easily analyze and know whether you are moving forward or you have any hiccup in between, and try to work on any challenge which arise. So for now, it's not that difficult to be able to know whether we are performing well or we are not performing well, because we have a very good system in place as compared to the previous time.
If we start to look a little bit ahead now, into the future, on the level of the project, I'll stay with you. What results do you see already now for yourself? Are you satisfied how far it's gone? I would say yes, but could you specify a little bit more? What is the kind of satisfaction that you get?
I'm very happy with the project, what we have seen in Dodoma, and what we have seen in, now we are trying to see in Shinyanga, because when I moved to Shinyanga, I used to work in Dodoma, I tried to copy all the ideas on the system strengthening protocols and other things based on the HPSS project, and they seem to be working, one of which is on medicine availability. So my belief is that if we should be able to scale up the project to the entire country, then Tanzania will be witnessing or be able to receive the best care or deliver the best care to these people. But the challenge again, it will be the pace I agree with Suzanne that, this is a process. We need to win slowly, to move from one region to the other, and to address whatever challenges or the lesson learned which we experienced from the previous regions.
So what would be the next steps? Already going to a next region, or stay within that region and go the furthest steps?
We'll be moving slowly,
right.
Stepwise. We have now 2 regions, but we would love maybe to incorporate 5 regions as a third phase. And from there, we can say now we are confident enough to enroll the project to the entire country.
So what does that mean as a way forward for SDC in Tanzania on a national level?
By going to 2 new regions, this means that we can compare whether the approach of the HPSS can work in all the regions, because we're only in 1 region. So with these other 2 regions, it gives us leverage for comparison and to convince our government also, to show them that what the mandate they gave us, this is what we can produce. And taking into account that we are at the policy dialogue level, where we bring in different development partners. The government is the one that is chairing the policy dialogue forum, and there are also non-governmental organizations, there are research institutes, there's the private sector. So this gives us room to show what we can do. So what we'll have to do now that we are rolling out to 2 regions and the additional one is to show what we can do. And by rolling out, it means that what we are going to do in Dodoma now, we are going to consolidate the experience for the first phase and see what can be replicated in these 2 new regions. And after the replication, then it will be the political decision of the government of Tanzania to see how they can scale up. But since there are other development partners who are also working in the health insurance schemes, different schemes, parallel schemes that are running in parallel with the government community health fund. So it's going to give us an opportunity to see how we can sit with the government on a round table and discuss on how we can harmonize and coordinate the different health insurance schemes that are now being implemented in the country.
But you sound pretty much optimistic that you're on a positive way out there.
We are quite optimistic, yes.
Yeah. And I see you smiling too.
Indeed.
If we take it back to the global level with Ms. Amsler, what do you do with all these experiences now, if I say in Bern, in Switzerland?
In Bern, we try to, of course, from projects like in Tanzania and from other projects, to gather the lessons learned and experience and share that widely between the projects, but also with the larger public. We've already been approached by other countries who are interested to use the software to manage their healthcare insurance system that they're building up. So that's certainly one element that we're trying to do in Bern. But what we learn from Tanzania and other projects, we also try to use in Geneva and in New York, for example. So I mean by that Switzerland is a member of multilateral organization of the UN, contributes to different international organizations. At the multilateral level, in Geneva International, for example, where WHO, the World Health Organization, has its headquarters, we have regular discussion, and Switzerland as a member state engages very actively in the discussion and the decision-making about the global health strategies and policies. So we try to bring in the lessons learned on health financing and health insurance there. Then in New York, for example, we have heard that next month the Global Development Agenda that is running up to 2030 will be approved in New York. So the discussions have been on for many, many months and years even. So in the area of health, we engaged in the discussions and we saw that the question of access was very prominent from the beginning. But most of the discussions were just turning around health financing. So we constantly, as part of the Swiss position, said that the financial aspect is extremely important, but it's not the only element. So we really bring in what we have as experience in the field to discussions in New York and Geneva. And maybe a last point that was mentioned several times today as well, it's not only to think within the health issues and health system. We have seen how crucial education is to influence health in a positive way. We have experience that show very clearly that farmers who have a bad harvest, they may not be able to enroll in the next year to health insurance. So you can very clearly see the link between the different realities or elements of life. So I think the connection between the different themes and sectors is something that we also try to bring forward in discussions at global level.
So we've gotten in a couple of questions. Thank you very much. I would like to start with the first one, which is very concrete. I think on a local level, on a community level, it says there's often no electric power. What then? What if the clinic is unserviceable?
Thank you very much for very nice questions. Looking into the gadgets which we are using for enrollment, we have provided them mobile phone together with solar power panels.
Okay.
So they can recharge their mobile phones at any place without depending on electrification.
So that's the mobile phones. And what happens with the clinic if there is no electricity?
Basing on the collection, there is also allocation which goes to infrastructural development. So when I was working as a district medical officer, we had to put aside some funding for electrification using solar power or using whatever means which is available locally, and also other funding for motivation or incentive for the staff who are working at healthcare facilities.
Another question that came in from the audience, how is data protected? Which is a typical Swiss question, of course. But I had the same idea when I saw the pictures being taken, and then with the QR code, I thought to myself, how are they going to protect that? Is that an issue, or how is that issue taken care of?
We have the central server, whereby all the data generated at the field is forwarded to the central server. So we have some limitations at each level. There's access to the district medical officer, access to the health facility providers. At different levels, there is limitation of access. So you cannot just access everything from the community. Right. So there's some limitations at each level.
Right. I think the second question was already more or less answered. It says, is the system going to be extended to the whole country? I think you would say yes, we're working on that, and we have a time horizon for the next more than couple of years. I'll move on to that question here. How do you convince people to pay money up front without knowing whether they will get sick? How do you do that?
That's a challenge for Tanzania because insurance is a new thing. People are not so used to, and it also goes back to the cultural belief. Why should I pay for money? It's like I'm predicting I'm going to fall sick.
Right, yeah.
So it's taking a lot of effort. That's why we are still very low nationally as per our enrollment rate for the Community Health Fund. It's only at 8.4%, while the target for this year, 2015, it was 30%.
Okay.
So you can see there's so many challenges, including the cultural belief, and also the awareness of why it's important for me to pay upfront. It's going to take a lot of time before people can really get used to this because, unless now since you're going to the mandatory health insurance, that's going to make people start realizing that it's important to enroll. But I think another thing is with regard to the quality of service that is in place. I enroll, then I don't get the good quality of service. So why? I better just go and pay at the private health facility where I'll get good care, good diagnosis, and the medicine is there, inclusive of everything. It's a full package. So, yeah.
Right.
Yeah.
Okay. It goes a little bit into the same direction, the social acceptance of the insurance concept. How is it socially accepted at this point? I would say we have more or less answered that. It's on the way up, right? Yeah. Are there Swiss residing in Tanzania helping to implement these projects? The last question.
We cannot say the Swiss residing in Tanzania. We have a very open process for identifying implementing partners. For example, the Health Promotion and System Strengthening Project, we had to go through a tender process. And this tender process identified the Swiss Tropical and Public Health Institute as the successful bidder. So it's a very open and transparent process for us to identify who is going to implement a project that is mandated by the SDC. Yeah.
Right, I think all questions have been answered from the public, from the audience. Thank you very much to you two for sharing your views. And thank you for your presence here on stage. Thank you. Jacqueline, Matoro, Ntuli Kapologwe, and Ursula Amsler. Thank you.